Sir, it is 7 o'clock. Can we wait for 2 more minutes for more people to join in? Dr. Sir, can we wait for 2 more minutes for some more audience to join in?
Yeah, Ganesh.
We will start by 7:03 or something like that.
Yeah, sure.
Thanks.
We can wait up to 5 minutes.
So can we start, sir? Welcome, Dr. Raja Silvaraj, and welcome all the other cardiologists who are present in this program as attendees for the Pacemaker Education Program for Young Cardiologists. Today is the fourth leg in which Dr. Raja will be discussing about pacemaker implantation, procedure, and technique. A few words about Dr. Raja. Dr. Raja Silvaraj is the head of the Department of Cardiology and Cardiac Electrophysiologist in Jipmer Hospital, Pondicherry. He has done his fellowship in cardiac electrophysiology in University of Toronto, Canada. He has around 120 publications in peer-reviewed journals, books, and book chapters. He has got a vast experience in cardiac implantable electronic devices implantation, follow-up and troubleshooting, electrophysiological studies, RFA procedures, and mapping. He is an associate editor in Indian Pacing and Electrophysiology Journal. He has been the reviewer for many national and international journals, including Heart Rhythm, Europace, Circulation, Arrhythmia, and Heart Asia. His area of interest is teaching and teaching electrophysiology for cardiology trainees. And he is proudly claiming that he is a passionate teacher in his blog also. And he has done a lot of pacing maneuvers. And another area of interest of his is 3D mapping. Welcome, Dr. Raja.
Thank you, Ganesan. And once again, thanks Medtronic for organizing this. And so today's talk is on the implantation procedure. So sort of primarily aimed for people who have either started doing a few implants or have assisted sufficient cases to have some basic understanding of what we are doing in this. And it's a long topic ideally, but since we have planned a time of about 1.5 hours, we'll try to go through it with leaving sufficient time for discussion. So to start off with some pre-procedure preparation, as part of the pre-procedure evaluation, always you should know the indication for the implant, and you should have decided on the pacing mode. So ideally, these should have been done well before the implant procedure. And we've discussed already previously about the indications and choosing pacing mode. Specifically, when it comes to implant, you should also have decided beforehand which side we are going to do the implant and discuss the procedure with the patient while taking consent. So I'll come to a little bit more on how we decide on the side. Other usual parts of the pre-procedure preparation include usually the patient is fasting for 4 to 6 hours because we might have to give contrast, we might have to give anesthesia, so it's generally better to have them fasting. But very important to remember to keep them well hydrated. So especially if they are fasting for a longer time, you might consider giving them saline infusion. This is important for all procedures, but especially for pacemaker procedures where venous access can be quite difficult if your patient is dehydrated. So that is something to keep in mind. Usually all patients coming into the lab for a procedure have a venous cannula in place. But for pacemakers specifically, depending on which side you're planning to do the procedure, try to have an ipsilateral venous cannula so that if you need to have a venogram done, you don't need to obtain venous access at that point. Some usual blood investigations are done. And as regards drugs, coming to antiplatelets, aspirin we no longer consider an issue. And if patient is on aspirin and if there's an indication, we usually continue aspirin without stopping. But dual antiplatelets can be an issue. So if it is dual antiplatelets, you reconsider the indication for dual antiplatelets. If patient has had, for example, a drug-eluting stent within the past month and therefore the dual antiplatelets cannot be stopped, then you will have to continue and accept a higher risk of bleeding. But otherwise, you can try and at least withdraw one of the antiplatelets. As regards anticoagulation, most of you may be aware of changing trends in management over about the past 10 years with a lot of evidence accumulated that oral anticoagulation is much better, both in terms of reducing bleeding complications and reducing thromboembolic complications compared to a strategy of heparin bridging. So almost always now we continue with anticoagulation. Depending on the thromboembolic risk in a particular patient, you may decide to do with full anticoagulation, maintaining therapeutic INR, or withholding for a day or two to let the INR drop to around somewhere between 1.5 and 2 and do the procedure. The decision to have a chest X-ray done routinely pre-procedure varies among different practices. So when I trained, we used to do this on a regular basis. Now we don't do this all the time. At least selected cases consider that, especially because if you have some problems and if you have a post-procedure X-ray which shows some changes, it's useful to have a baseline X-ray to know whether something was there before the procedure. When it comes to part preparation, still most of us continue to shave to remove hair over the area that is being prepared. But there is some suggestion that trimming the hair instead of shaving may be better in terms of asepsis, because shaving does produce some abrasions which can promote colonization in that region. So electric trimmers are available, and so if that is a possibility, I prefer to trim rather than shave. Some institutes use a antiseptic scrub even the day before the procedure. So there is some not very good, but some evidence suggesting that this might help reduce rate of infection. So if you do that, you can do that. Otherwise, it's usually done on the table. And then draping is as usual for surgical procedures. And the drapes may or may not have a skin film. We also have skin films with iodine impregnated, so sometimes you can use that also if it's available. Coming to anesthesia, so we usually do this under awake sedation. And then we give local anesthesia. For local anesthesia, we usually use lignocaine with bupivacaine in a 1:1 ratio. And the rationale behind this is that bupivacaine has a longer half-life, so it provides coverage for a long procedure like a CRT, and also for the shorter procedures, it provides a good amount of post-operative anesthesia. So that the patient doesn't feel pain for about almost 4 hours after the procedure. So you should have bupivacaine. As far as lignocaine, you know that it comes as a 2% solution. So it's better to dilute it to 1% or 0.5%. Remember that the maximum allowable dose is 3 to 4 mg per kg. So if you use 1%, you can usually use 20 ml reasonably in a 60 kg adult. So it's better to have 20 ml of 1% rather than 10 ml of 0.5%. We need some amount of volume to get good anesthesia. And like I mentioned, we usually use conscious sedation with a mixture of fentanyl midazolam. So this again, there are multiple studies in various settings with minor procedures, with endoscopy, EP procedures, and pacemaker implants, etc. That you don't need an anesthetist to do this, and it can be physician or nurse monitored. Just giving fentanyl midazolam can be fine. Again, there are centers in the West where all these patients are done under general anesthesia, all implants. It does make it a little easier and faster for the surgeon, but I don't think it is worth the slight additional risk of exposing a patient to anesthesia. Instruments, you would be familiar with most of the instruments. It's important to, sometimes people who are mostly into EP or general cardiology and do implants once in a while may not be familiar with the instruments. So usually use hemostats of various sizes. You have small hemostats, the mosquitoes for catching bleeders, and then you have the other hemostats. Alice tissue forceps are sometimes useful for retraction, sometimes even to hold the device. Scissors usually come in two forms, the Mayo and the Metzenbaum. The Metzenbaum scissors are more delicate and are usually used for cutting tissue, and the Mayo scissors are harder and are usually used for cutting sutures, and sometimes for other extraction procedures we need to cut lead and other things. So generally it's preferable to keep these separate so that the Metzenbaum scissors remain sharp. You don't use that for cutting sutures. And then you have tooth forceps and the regular non-toothed forceps. Usually tooth forceps is only used finally for the skin when we are using the subcuticular suturing. And we usually use two knives if you're not using cautery. One would be a skin knife, and once we incise skin, we generally don't use the same knife for the dissection of tissue beneath to maintain some amount of asepsis. So typically a 20 blade is used for the skin, and then 11 blade is used for deeper dissection. But if you use cautery, we usually forego this 11 blade and use cautery for the tissue dissection. Remaining are needle holder retractors. Very useful to use a self-retaining retractor, which we use always, but sometimes I see when I go to other centers that they do not use this. So strongly recommend using a Whiteliner self-retaining retractor because it keeps the wound open, shows you the floor of the wound, and it avoids you making unnecessary repeated incisions in different places. So you use the self-retaining retractor to stretch the tissue, and then you cut the stretched tissue. That way you reduce the amount of trauma that you produce. Now, choosing side is often mentioned in books and discussed a lot in previous descriptions in textbooks, etc. And if you know, there would be discussion on profession, on handedness of the patient and all this. Mostly these are irrelevant today because the devices are smaller, they don't really interfere with movement that much. And because we use more and more of ICDs, CRTs, where it's very much more important to do the device on the left side. So currently I would say by default, all implants should be done on the left side. 99% of our implants are on the left side, and unless really required, you do not go to the right side. So this is important to obtain a good vector for ICD shocks, and also especially in CRT when you have to cannulate the CS, etc. Left side is much better. So left side is preferred, so it is the most common one to use. It provides a easier route both to the right ventricle and the coronary sinus. The only problem with a left-sided implant is that occasionally you have a patient with a persistent left SVC. It's there in about 1 to 2% of patients. And if you have a persistent LSVC, going on the right side, if usually there's a bilateral SVC, there's a bilateral SVC going on the right side, you can do the procedure as usual. But on the left side now it becomes a problem because you'll go through the LSVC unless there's a good bridging. When you go through the LSVC to the coronary sinus, and placing leads can be more difficult. Whereas right side in other generally is difficult because of the angulation, and like I said, in ICD it provides a suboptimal shocking vector, and then CRT it makes it much more difficult to cannulate the CS. So generally prefer to avoid it. So this shows how the route when you puncture on the left side provides a natural straightforward curve to go into the right ventricle. Whereas if you come on the right side, your lead has to keep changing directions, and that makes the implant procedure more difficult. The problem, like I mentioned, on the left side is the left SVC, and especially if you don't do venograms beforehand. So some centers do routinely a venogram beforehand and try to identify this. And so if you know beforehand, you can directly switch and do on the right side. What we do usually is in the pre-op echo screening, we look for a dilated CS, and if it's absent, we assume. So that is also fairly reliable. But if you don't identify, and if you land up with a LSVC on the table, this is what usually happens. And this is an AAI implant, so the putting in the atrial appendage or somewhere on the atrial septum is usually fairly straightforward. You can do it like this. Putting in the ventricle is a little more difficult, but in this patient, we have put it in the ventricle. You can see the lead curving here. So you can see that you have to sort of take a curve against the natural direction in which the lead exits the coronary sinus. So it's a little more difficult to get into the RV. So if you know that patient has LSVC, it might be better to avoid going on the left side and do a right-sided implant. So this is something which again varies with how each center does. You can consider doing this for every patient, at least in the early part of your practice. So they do a venogram before the incision, so you know beforehand about venous patency, presence of LSVC. But we generally don't do this because there is definitely, of course, a small risk and slightly increased time, everything with doing a venogram in every patient. And we don't feel it is worth the extra additional benefits that you get from it. Like I said, we screen for LSVC by looking at the CS and echocardiograms, and that is generally sufficient. Now, skin incision, there are a couple of different ways of doing it. I think more and more now, mostly we do a horizontal skin incision where it's totally horizontal in relation to the patient. We do it about 2 finger breadths below the clavicle. And generally we site it such that the deltopectoral groove crosses this incision at the junction of the lateral third and the medial 2/3 of the incision. So the groove comes in the lateral third of the incision. Some people who regularly get the cephalic vein, usually trained before, prefer to do an incision parallel to the deltopectoral groove, right on the groove. My main concern with this incision is that it may make it easier to get the cephalic vein because you're opening right along the course of the cephalic vein. But the pocket tends to be very lateral with this, and a lateral pocket is a major problem in that it leads to device erosions. So whereas if you make a horizontal incision, the medial end of your incision is much more medial, and you can make a pocket which is much more medially sited, which lowers the risk of erosion significantly. You have to plan the length of incision beforehand. It varies quite a lot depending on the device. If you use a Medtronic single chamber device, the current devices are very small, and an incision of about 1.5 to 2 finger breadths is sufficient. A lot of these things it's good to think of in finger breadths, or you should know what 2 of your finger breadths are. Like I know 2 finger breadths is going to be 3 centimeters. So like that you should probably know because it's very easy to measure that on the table. So depending on whether you're going to put a single chamber pacemaker to whereas you're going to put a larger ICD, length of incision may vary. And this I've already discussed. Once you make the skin incision, you use a self-retaining retractor to stretch the tissue and then proceed with sharp dissection. Now, some people trained in using blunt dissection from this stage. So blunt dissection leads to more tissue trauma, more bleeding. So that increases post-operative pain, increases risk of infection. So always use sharp dissection. You can use 11 blade, you can use cautery and dissect with sharp dissection. Now, as you dissect each layer, you reapply the self-retaining forceps to again stretch the tissue, and you look at the floor of the wound properly. That way you'll identify when you reach the deltopectoral fascia. So the ideal should be not to breach the deltopectoral fascia, which means you will see pink muscle underneath, but that will be covered by a sort of whitish layer, which is the fascia. Whereas if you disrupt the fascia, you'll directly see the raw muscle and the pink and the muscle fibers. So that, again, once you disrupt the fascia, you tend to get more bleeding. So generally try to avoid disrupting the fascia. Once you reach the fascia, you can dissect for the cephalic vein if you do that. So basically, venous access, there are three major access routes that you have a choice between. And these are the cephalic vein, the axillary vein, and the subclavian vein. There are a few others which are very rarely used, so not going to discuss too much of that. And in our practice, most of the venous leads end up being placed through a cephalic vein, at least 50%, but more like 75%. And what I mean by assisted is that is in some of these cephalic implants, about 10 to 20% of the cephalic veins, the vein may be small or may have angulation preventing a lead being directly placed through the vein, and you may need to put a wire or a sheath to help take the lead in. The remaining cases, almost when you don't use the cephalic vein, or if you put one lead through a cephalic vein and need an additional venous access through some other route, almost all of these go through the axillary vein for us, which is basically, which sometimes otherwise people call it as an extrathoracic subclavian vein. So a puncture outside the subclavian vein. And this usually we do without a venogram by fluoroscopy, but some cases where we don't get it in the first couple of attempts, we may do a venogram. Extremely rare in our practice to do a subclavian vein puncture. So I would, I think in terms of most institutes who are experienced now, the only difference might be in the percentage of cephalic veins used. Some people prefer to directly go for axillary vein puncture, but subclavian vein puncture is definitely the one that you should not be doing as a primary strategy. You should be conversant with the anatomy of the upper limb veins. The axillary vein, as it comes out here and runs up, and when it crosses the first rib, it becomes, after that it's called as the subclavian vein. And then you have the cephalic vein, which runs in the deltopectoral groove and then joins the axillary vein here. And fluoroscopically, this part of the axillary vein, the place where it crosses the first rib is exactly where the clavicle crosses. So you see where the clavicle is crossing the first rib, and usually the lower border of the clavicle would be where the vein crosses the first rib. And from there, tracing it laterally, it generally parallels the posterior border of the second rib also. So if you generally sort of think of this fluoroscopically, you know where the vein is, and you can just puncture even without doing a venogram. Now, if you're accessing the cephalic vein, which is what we do, usually what you do is once you reach the deltopectoral fascia, you will be able to see the pectoralis major muscle in the medially, and just lateral to that, you'll see the yellowish fat in the deltopectoral groove. Once you can see that well, like an anatomic dissection, almost always you can identify the vein. So you just have to open that pad of fat and you'll see the vein lying there. Once you see the vein, we usually plunge a scissors medial and lateral to the vein and stretch the tissue to break all tissue adherent to the vein. So it's important to separate the vein from all adherent fascia and other fibrous tissue. That way, when you make an incision in the vein, you will not be going into false channels. And then you can put proximal and distal ties. And the distal tie, that is the one closer to the hand, you can tie it and use that to control the vein. And there'll be a proximal tie, which is more used for hemostasis. And then, so this is how the anatomy will look when you open here. Generally, if you see the muscle like this is fascia is disrupted. So usually I don't like to see muscle like this. You should see a whitish covering over this. but in the lateral part of the incision, you will see the yellowish pad of fat. And once you open this fat, the vein will be coursing in a 45-degree angle like this. Then you put two ties. This tie is tied, and you can stretch this, pull this towards you to get good control of the vein. You make an incision and put in the lead. And this tie, which is proximal, which is closer to the heart, you can use for hemostasis. If it starts bleeding here, if you just pull this up, the bleeding will stop. Now, like I said, some cases, what happens is the cephalic vein, you get the cephalic vein, but when you put in a lead, the lead doesn't pass. So the general strategy I do usually is put in a 4F dilator just into the vein, do a contrast injection there, and try to identify the reason why we are not able to pass the lead. This is usually due to an acute angulation, spasm of the cephalic vein, or some narrowing at the junction of the cephalic vein with the axillary vein. And depending on the amount of obstruction that is there, you might be able to pass a hydrophilic wire, cross it, and then take a sheath, or you may be able to, or you might have to go for a 014 wire and then slowly upsize your sheath and then put a larger wire through that. Once you have a wire in, that itself might remove the angulation, and you might just be able to pass a lead parallel to the wire. But if that is not possible, over the wire, you can put a peel away sheath and then take the lead. So like this is a picture of cephalic vein that you can see here, and you can see the angulation. So the vein turns 90 degrees, and then at the junction again it's a 90 degree. So sometimes because of this, it doesn't take the turn well, and like sometimes like this, there is a little bit of narrowing at the junction of the subclavian vein. And so again here there seems to be probably spasm of the vein after it a spasm here at this as it is entering the vein. So these are things that can happen sometimes. So when you think of the pros and cons, I think the cons are, so usually people are worried about the learning curve. So people who have not been exposed to using the cephalic vein during their training think it's a difficult procedure to do, and therefore they don't attempt it at all. So what we try to do is train everyone in getting used to this first, because once you do about 10 cases also, you get confidence. So the first 20 cases, you might get it only 25 to 50% of the time, but after that, it's slowly improve, and then you'll start getting it 90% of the time. So it's not too huge, but it's a good thing to do, because then once you don't get the vein anyway, you go for an axillary vein. That way, you know two techniques instead of knowing only one technique. It does add a little bit of time to the procedure, so which is why people sometimes prefer to just directly go for axillary vein puncture, because they think that you're wasting time trying to search for a cephalic vein. But again, once you have a little bit of experience doing this, it adds no more than 5 minutes. In 5 minutes, usually you have the cephalic vein, or you know that you're not getting the vein, and you drop it and move on. So usually it doesn't add more than 5 minutes to the procedure. One definite problem is that it is a little bit more of a painful part of the procedure for the patient, because it's a whole neurovascular bundle which runs in the delta pectoral groove, including a small artery and a nerve. So that area tends to be a little painful no matter how much local you give there. So it varies. Some patients it is more, some patients it is less, but that may be one of the issues. And in more and more, we are doing procedures where we place multiple leads. It might be a problem. Usually, if you're doing a dual chamber implant, I would say at least 50% of the dual chamber implants, both the leads go through the vein. But if not, then one of the leads might have to go through another vein. But when it comes to CRT, usually you need additional venous access. The major advantage why we advise so much to use a cephalic vein is there is absolutely no risk of a pneumothorax. So there's no reason why you would get a pneumothorax with a cephalic vein puncture. And there is also almost no risk of a lead crush. So the lead crush doesn't happen when you use a natural venous channel to cross the clavicle. So when you don't do that, when you puncture under the clavicle, you can get into a place where the clavicle and the first rib act like a vice, press on the lead, and can result in a lead crush. Now the second approach, which you can use as your primary approach, or you use as your fallback approach when you don't get the cephalic vein, should be an axillary vein puncture. Again, there is a little bit of learning curve, and people who have not learned to use an axillary vein puncture, who have trained primarily using a subclavian puncture they're used to a subclavian vein puncture for either placing central venous lines or dialysis catheters. So sometimes prefer to keep doing the same subclavian vein puncture when they come to start doing implants. So I would definitely say take the little bit additional time that it takes you to learn an axillary vein puncture and do it. Usually, we do it as a fluoro-guided approach. And like I said, try to puncture it on the body of the first rib. And the anatomy is you look at the lower border of the clavicle, and that is where it would be. So you can try a little higher than your expected place. And then what you do is you just keep withdrawing and go back slightly lower every time. And this is called as walking along the first rib. You basically explore along the first rib. It has to cross the first rib somewhere in that region. And if you know you're at the right depth, such that your needle scrapes the periosteum of the first rib, you will get it somewhere there. If you don't get it in a couple of attempts, you can always better to do a venogram and then get an idea of where it is. So there is a definite learning curve, but it's small. It does need fluoroscopy, which is why it's not very ideal for placing, say, catheters in the ICU. But in a cath lab where you're doing the implants, where you anyway have fluoroscopy, it's not a major con. People think you always need to have a venogram, but that's a myth. We probably do a venogram in less than 10% of our axillary vein punctures. Now, the risk of pneumothorax is very low. Theoretically, you should think it should not be there because you're puncturing outside the thorax, but it is there, although it's extremely low compared to, so for example, if with a subclavian vein puncture, I would say it's about a 5% risk of pneumothorax. Axillary vein puncture, it should be like 0.5% or so. So the pneumothorax, when it happens, is either because you stray beyond the first rib, so you're entering the thorax once in a while, or sometimes you might puncture the lung if you go deep between two ribs. So you go between the first and second rib and you might directly puncture the lung. So these are the reasons why you can get a pneumothorax. And here again, you should not have any risk of lead crush. So like I said, the last fallback thing is subclavian vein. So this we end up using usually in the setting where multiple attempts we have not got the axillary vein. And typically what happens in those cases is sometimes if you've done an inadvertent axillary artery puncture, or you punctured the axillary vein a couple of times and not been able to pass a lead, the whole vein goes into spasm. And if you do a repeat venogram, you see that all the axillary vein is in spasm and the vein only sort of reforms medial to the first rib. Then you might have to go for an axillary vein, subclavian vein puncture. So subclavian vein puncture is a technique most of you are familiar with. You can do it without fluoroscopy, and you go with a very shallow angle beneath the clavicle and you can puncture this. So overall, people are more familiar with this access method, and anatomic landmarks are sufficient. You don't even need fluoroscopy, but there is definitely the highest risk of pneumothorax compared to the other methods of obtaining venous access, and there is a definite risk of lead crush. So this is a patient who had an implant done outside, done somewhere else for heart block. Patient came with lead issues, and fluoroscopy, you can clearly see here that there is compression in that place with crimping of the conductor, and so this is right at the point where this is where typically this happens between the clavicle and the first rib. So this tends to happen with subclavian vein puncture. I'll later discuss some ways you can try and avoid this happening. Now, coming to sometimes if you get an access and your second access you have difficulty getting, just know that don't keep on trying. You can use a single puncture to place multiple leads. Okay. So what you can do is basically if you got one venous access, you want to put a dual chamber device. If you see the lead boxes, they give two recommended sheath sizes. So one will be to place a lead alone, and another will be to place a lead with a guide wire. So for example, a regular usual 58 centimeter Medtronic lead will say a 7F sheath for the lead and a 9F sheath if you put a lead plus guide wire. So this is called the retain guide wire technique. So what you can do is you take a 9F sheath, put the lead, don't remove the guide wire, keep the guide wire also. So you put the lead in, and then when you split the sheath, now you still have a guide wire left. Over that guide wire, you can put another 7F peel-away sheath and take the atrial lead over there. So this is called a retain guide wire technique. If you don't have a 9F sheath, what you can still do is put a 7F sheath, put two wires inside, and then take out the sheath and then now pass the sheath over one of the wires. So now you have another wire. So you can obtain multiple accesses over a single puncture. Some centers do this routinely. So some people prefer to do this routinely. avoid this on a routine basis because I think it leads to a larger hole. So we prefer two smaller holes instead of one larger hole. But in case of difficult punctures, just know that this is a technique that you can fall back on. A few tips for puncture of the axillary vein, basically, but also for subclavian vein. One is when you're going for puncture, we usually keep lignocaine in the syringe. So you keep a little bit of saline in the syringe. Instead of saline, we take some lignocaine in the syringe. And how this helps is that when you usually go and you're scraping the first rib, patient may have pain because the periosteum is very pain sensitive. And if that happens, you can usually inject some of that lignocaine there and makes it more. When placing, some people are used to puncturing subclavian vein by placing a roll under the shoulders and to sort of stretch it out. So that is not recommended to be done. So the problem is that this artificially opens, creates some space between the first rib and clavicle, may make a puncture easy. But then once the patient returns to a natural position, the space will close down. So you're putting a lead through a space which is non-existent, and then the space closes down later. It will pinch on the lead and produce lead crush. So avoid putting a roll under the legs, shoulders. Third is if you're doing in an operating table, while doing the puncture, you can put a patient in a Trendelenburg position. So you put the patient head down. If you're doing in a cath lab where you can't go head down, head up, you can elevate the legs if possible. You can put a couple of pillows. You can do this automatically when you do the puncture, or definitely do this once you have difficulty in getting the vein a couple of times. So the two reasons this is helpful, one is that it dilates the vein a little, especially in a patient who is slightly underhydrated. This makes it easier to puncture the vein because the vein becomes engorged. And the second advantage is that that it reduces the risk of air embolism, because you increase the venous pressure in the upper part. The chance of air getting in through a sheath of this becomes smaller. So this is a good thing to do on a routine basis if possible. Always very important to verify venous access before putting in a sheath. Don't think that when you aspirated, flow was not pulsatile and blood looked dark, so this is a vein. Can be misleading in patients with heart failure who might have a fairly deoxygenated arterial blood, and also where your needle might be slightly against a wall, and so suppose if you do an inadvertent arterial puncture and your needle is against the wall, you may not get that much pulsatile flow. So it has repeatedly happened in various places that people mistake an arterial puncture as venous puncture and end up putting a lead into the artery and into RCA and things like this. So always confirm that you have punctured the vein, and the typical way to do this is to confirm that your wire crosses the diaphragm and goes straight down below. That tells us you're on the IVC. We always do that. And like I said, for important air embolism is a rare complication, but it does happen. And important steps to avoid it is to keep the patient hydrated adequately, use a leg elevation if possible, or head down position when possible. And whenever you have an open sheath, keep it pinched. So you put in the wire, you pass the sheath and dilator over it, and when you remove the dilator and wire, keep a little bit of sheath outside and pinch that well to prevent air getting in while you place the lead. And as far as possible, don't keep a sheath in for a long time. As soon as the lead goes in, we park the lead in the mid RA and then split the sheath. In cases like I mentioned, you can either opt to do a venogram automatically in all patients before puncture, or like we do when we try to puncture everything without a venogram, and then only when you are unable to get a puncture, then we do a venogram. One exception is in patients with pre-existing leads. So, for example, if a patient has a VVI device for 20 years and you're planning to upgrade to a dual chamber device, so always whenever there's a lead which has been in for more than 5 years, prefer to do a venogram. Many of these patients will have either narrowing of the vein or even occlusion of the vein. It's important to identify that beforehand so that you can plan accordingly. So when we need to do a venogram, we usually give 10 to 15 ml of contrast, preferably through a large bore cannula on the same side. And remember that it takes some time for the contrast to run in from the arm till the subclavian vein. So you can start injecting and just check with fluoro once every 2-3 seconds. Once the contrast reaches that part of your axillary vein, we start doing the cine. And I'll show you some example later. It's very useful to try and puncture while you're doing the venoplasty. So let me see if this runs. So this is, for example, you can see the contrast running there. And then as it is running, when you puncture, you can see the indentation of the vein. Okay, so just run it again so if you can see it. If you take your needle while the contrast is running, so you can see how you indent the vein, and you'll see it pops and it will go into the vein. So it helps you identify what is your level of depth. If you're not seeing indentation, you know you're not at the right depth when you're going. So while contrast is still in the vein, try to puncture. It helps. I'm not going to really cover the unconventional access. Extremely rarely required. In our 10 years here at JIPMER, we have not had required this in any of the patients. So let's not cover this here. Once you have venous access, you have to place the leads. We're going to cover only more traditional lead placements. Obviously, there are a lot of newer approaches now, which, if at all, we have to cover only in a more advanced class. Now, the first and most important thing that people have to get familiar with is, of course, place a lead in the right ventricle. Beforehand, you have to choose what leads you want to use. Now, our practice has slowly changed from about 15 years back, putting a lot of passive leads, to switching to 50% of active and 50% passive leads, to over the last 5 years or so, all our leads are now active leads. So mostly we use active leads. The advantages with the active leads is definitely a lower risk of lead dislodgement, but most importantly is that the ability to place a lead in multiple different places, allowing you to give a more physiologic activation. So for that reason, we mostly use active leads. Leads come in different lengths. You should be aware of these things. And standard lengths are 52 and 58 centimeters. And the 52 centimeter lead is sufficient to place even in a ventricle in shorter patients. But for usual normal patients, usually you prefer a 58 centimeter lead in the ventricle and a 52 centimeter lead for the atrium. Now, remember that if you are going to place a lead and monitor its placement only in an AP view, there are a couple of things which can mimic appearance of a lead in the right ventricular apex. One of the most important is when a lead crosses through a PFO into the LA and then goes into the LV. It can be very difficult to distinguish this in a AP or PA view. Even though the experience you can suspect it, not very easy, so you can easily get misled. And again, this is well documented in multiple case reports that people have inadvertently put in the LV, not realized at all, and then later then you have to decide whether you can remove it or that keep the patient anticoagulated and various things like that. Less common, but again, thing that can happen is that you, from the RA, instead of crossing the tricuspid valve, you enter the coronary sinus, place in a posterolateral vein. Again, can look very misleading on a AP view. Again, a less common thing is sometimes from the RA you go into the IVC and it goes into the left hepatic vein, and it will be just beneath the heart, but almost might look like going very low in the RV. So these are all things which can happen. And one good way to sort of avoid all these things, of course, in a cath lab, you have a flexibility. You can go do a good LAO, RAO views, and a lot of these things can be distinguished. But a lot of the times you're working in a PA view. So there, the best way to avoid these is to always first place the lead in the RVOT well into the PAs, because that eliminates possibility that you're in the coronary sinus or that you're in the left ventricle or you're in the hepatic vein. So you know you're in the right ventricle, and then you pull back and deploy the lead where you want to deploy without coming back into the without coming back proximal to the tricuspid. So we first use a gently curved stylet, place the lead in the RVOT, exchange it for a straight stylet, and put the lead in the RV apex for putting in the RV apex. Okay, so this is what we do: curved stylet, and you put it in the RVOT. So now this position automatically, once your lead reaches a position like this, you know you're not the coronary sinus, because coronary sinus will usually go till about here. You know you're not in the left ventricle, you cannot come and you will not get this appearance. You know you're not into the IVC or hepatic. So once you know this, you're now in the right ventricle. Now we take out this curved stylet, and if you want to place a right ventricular apex, we put a straight lead, straight stylet, and then deploy this in the apex. And when you place in the apex, finally the lead should look like this, where you place in the apex, and you should have this heel where you can see the lead comes up on the tricuspid valve, and in the atrium it again dips down. So when you have this, this is an adequate loop. When you place in the apex, always remember that the apex is the thinnest part of the heart or thinnest part of the ventricles, and therefore never push in the apex. You want to get to the apex, but if you can experiment, see this outside itself. If you don't have the stylet in, the lead is very thin. It's very flexible. It's like noodles. But once you put a stylet in, it becomes quite stiff. Right? And again, stylets come at different levels of stiffness. So that is again something that you should know. But especially if you put a stiff stylet, but with any stylet, the lead definitely becomes stiff. So you use a stylet to straighten out. You keep the stylet till the tip. But as soon as you reach close to the apex, when you're pushing it into the apex, you withdraw the stylet back so that the distal part is floppy and therefore you don't have a risk of perforating. With active fixation leads, we now place more and more leads on the septum. And what I'll show you here is images where you place in the high outflow septum, but more and more we place now in the mid-septal locations. Most of these septal locations, Harry Mond has initially demonstrated how to shape the stylet, and is generally called the Mond curve. So essentially, it's like an Amplatz curve in that it has a primary curve and a secondary curve, but where like an Amplatz usually is in 2 dimensions, like in the sense that it's a flat thing. If you put it on the table, it lies flat, whereas this is usually a 3D shape. So that if you put it on a table, the distal part should be going inside the table, so that on LAO view, that makes the distal part turn posteriorly so that it reaches the septum. So with that sheath, if you put this, for example, this is in a high outflow. So what we usually do is in the septum. So this is sort of the upper level of the tricuspid valve where the His bundle would be. So the upper part of the tricuspid valve would be taken as a cutoff point. Anything above that is called the high septum or outflow septum. Below that would be the mid septum. So this is a high septal placement. And with the high septal placement, this is the final appearance. And with the outflow tract pacing, you tend to get nice, very narrow QRS in some of the patients. You can know this is outflow tract by seeing that the paced morphology is upright in the inferior leads. And sometimes the lead is very narrow. So where you're not using the newer methods of conduction system pacing, you may still get a quite narrow QRS if you do these septal pacing instead of putting in the apical pacing. Even though the evidence for clinical benefits from this is still not very robust, now more and more we prefer to do this in almost all the patients. Younger patients who still have a lot of growth potential and you want to give some lead additional slack to accommodate for this growth that is expected and the lead stretching that is expected, you can put what is called as an alpha loop like this. So sometimes a little tricky to put. You place the lead as usual, and then what I usually do is pull the stylet back a little, and you can have a curve on the stylet to help it curve, and then you just push in an extra lead till it forms a nice spiral like this. And you should see that your loop is oriented in a way that it's not going to place a stress on the distal part of the lead, tending to pull it back or push it forwards. It should lie a nice loop like this. There are various ways of putting the extra loop, but this is one of the commonest ways of doing this. So this is a child, and especially smaller children, we tend to do this. Atrial lead placement, you can place either a passive fixation leads, which usually come in with a preformed J shape, or active fixation leads, which are usually straight leads, and you use a J-shaped stylet. And almost all the atrial leads we now place in the right atrial appendage, which is probably the very stable positions and relatively safe in terms of low risk of dislodgement or perforation. But you can place in other places also. So it's most important is to have a mental understanding of where the appendage is. So if you're seeing in an AP view, your lateral heart border is very lateral, tricuspid valve is medial. Somewhere in between these two would be the right atrial appendage. And if you see in an RAO view, the atrial appendage is more of an anterior structure. So it's sort of anterior, superior to the tricuspid annulus, and a little more lateral. So this is a passive fixation lead. Now the passive fixation lead has an inbuilt J shape. And by placing a straight stylet, we have removed the J shape. So all you have to do is, as you pull the stylet out, it reassumes the J shape. So what you do is you pull this lead back to the SVCRA junction, and then holding the stylet, just push the lead in. As it assumes the J shape, you try to direct the lead where you want to go. So if you do a clockwise torque, the lead will go more lateral, whereas if you do a counterclockwise torque, it will go more medial. And you know that your appendage is somewhere here, you try to reach that place. You identify that you've entered the appendage by seeing that the tip becomes fixed, and then the tip starts moving in a side-to-side movement. So I'll just try to show you this video. Okay, let me just start this one back. Right. Okay, so see here, we pull it back, and then as we come in, and then you see here, you see that this movement, so that movement is something that you should learn to recognize. And once you see that side-to-side movement, what is called like a windscreen, like a wiper that you have on the car, that is very typical of appendage. And for passive leads, again, you pull back the lead, make sure that the tip has reached the apex of the appendage. For active leads, again, very important that your lead may be just floating inside the appendage, and if you fix like that, it's not going to get fixed. So pull back on the lead, make sure that the lead tip is contacting muscle before starting to fix the lead. Now with active fixation leads, of course, you have a choice of positions. There was initially some interest in trying to place the lead on the Bachman bundle or on the septum to try and get more synchronous atrial activation. So that sort of the enthusiasm has gone now because there's not much evidence for that reducing risk of atrial fibrillation. And then sometimes you might need to place a lead on the lateral wall, sometimes if the patient has had an appendage excised previously and things like that. So with active fixation leads, you can do all this. VDD leads, single pass VDD leads are used less and less now, but these are valuable. These are very useful in patients with heart block where you don't really need to pace the atrium. So these single pass leads basically are like a ventricular lead, but they have a floating bipole proximally, which acts as for sensing the atrium. Placement is very similar to an RV lead placement, but you have to usually place the lead in the apex. There's no active fixation with this. And you have to, there are usually different sizes available depending on the distance from the ventricular bipole to the atrial bipole. And depending on your patient height, you might have to decide which one you want. So I'm not going to come to that because less likely that you're going to, in the future, that you're going to do a lot of these leads. Now, once the leads have been placed, you usually fix the leads and connect it to the device. Fixation of lead is a very important thing that you have to learn to do properly and learn to do well. A lot of dislodgements that people get in their early part of their career. So when you start doing pacemaker implants in your first 100 cases, I'm very sure you'll get 5 to 10 dislodgements. And you'll see that once you start go into your next 100 or so, this will come down to less than 1. So the early dislodgements, when you reopen them, you'll see that the lead is lying loose within your suture sleeve. So not able to fix it well is one of the important reasons. So you have to, so one is always use a suture sleeve. Some people try to cut off the suture sleeve and things like that. No, don't always use a suture sleeve because it allows you to put a tight suture without damaging the lead. And the suture sleeve has to be fixed well to the lead. It has to be fixed very tight. And the suture sleeve itself has to be fixed to the fascia. And that does not need to be very tight, but it has to be fixed well. So usually you can put 2 or 3 sutures also, but after you put your first one, confirm that it's very tight and the lead does not move through it. So test it always by holding the suture sleeve with a forceps and pushing in the lead a little and see that the lead does not move. Only then you go ahead and put the other couple of ties also. Now, once this is done, you push the lead into the device, and maybe I could have had a picture here. So if you know the picture, you have the connector blocks when you push the lead in, and beyond the connector block, there's a last part of the tunnel into which the lead goes will be clear. You can see that. Now, as you push in the pin, you should see that the pin comes into that tunnel. Okay? So if it doesn't come all the way there and you just fix it, it might be loose. You'll end up with set screw issues. So always see that you see the metallic part of the lead come into that distal part of the port, and then only fix it. And for fixing, you always come with a screw, and that is covered with a sort of silicone valve. So gently put the screwdriver through that, and then you rotate clockwise. And this wrench is called a dynamometric wrench. So what it does is, it'll only provide torque until a certain level of torque is reached. So if there is resistance beyond a certain level, while you're rotating the handle, the distal the screwdriver itself doesn't really rotate. And then it produces a noise also to tell you that it has stopped rotation of the sponge. So once you hear the noise, it means you're not transmitting any more torque and you can stop at that point. Always pull back on the lead, gentle tug to see that it is fixed well. With multiple leads, with dual chamber devices, CRTs, ICDs, etc., take a lot of care to see that the right lead is fixed in the right slot. So you may be able to identify this based on markers on the lead. Sometimes it's marked as 58 centimeters, 52 centimeters lead. It will also leads are not compatible sometimes. Like for example, with ICD, the ICD leads have a different profile. They're called DF1 leads compared to the IS1 for the pacemaker lead. So you might be able to identify based on that. But if there is confusion, you can again retest with the pacing system testing with the PSA to see which chamber you're pacing and then test. Or you have the lead boxes outside, double check the serial number. The serial numbers are always marked on the proximal part of the lead, double check the serial number and then screw it in. So again, this is something that happens once in a while, that leads are connected wrong. So it's a bad thing to have to go back into a patient just to correct your misconnections. Now, another important part of the procedure which you have to learn to do properly is to make a pocket. Now, the way we suggest doing this is the pocket should be in a correct facial plane. So you know, surgeons always, all your dissection should be within facial planes. That reduces the amount of trauma. If you're in the right facial plane, the dissection is very easy. It'll just split easily. You won't have bleeding when you split that, and everything else. So the risk of infection, pain, everything comes down. So you usually do sharp dissection to define the facial plane. And when I mean define the correct facial plane, what you should see is the floor of the pocket should be formed by the deltopectoral fascia. So you'll see a whitish fascia, the prepectoral fascia, otherwise what you call it. You see a white fascia, and below that will be the pectoralis major. So that should form the floor. You should not be seeing raw muscle fibers and bleeding tissue and things like that. At the same time, if you go too high, you will be inside the subcutaneous fat. So that again tends to cause problems with migration of the device and all that. So once you do a little sharp dissection with either scissors or with cautery, you define the facial plane, you see that you're in the right plane. You should use blunt dissection to expand the pocket to the size you want. Best done with fingers. See that your dissection, the neck is also dissected to the same extent as the pocket, because sometimes if you just put one finger and rotate it, you may end up with a narrow neck and just a wide pocket. So you want the neck also to be of the same dimension. And always sight your pocket as medial as you can. So you start your pocket from the medial part of the incision and go further medially. So if your pocket is sighted laterally, where the thorax has curves, the lateral edge of the device starts pushing against the skin, and that tends to lead to erosion in the long term. So sight your pocket medially. Now it's becoming less and less common that we're doing subpectoral pockets. We haven't done now for quite a few years because devices have become smaller and but you can use this when you have patients who are very thin, patients who are very small. It gives very good, cosmetically very good results. You will almost not see the device superior outside. So if you have a large device, small patient, you can use a subpectoral pocket. If you have a little experience, you can do it yourself. You don't need to call a surgeon, but if you're not comfortable, you can call a surgeon, because if you do get bleeding and all this, sometimes it's very deep and you might have difficulty controlling that if you're not used to it. The usual way we do is, so the pectoralis major has two heads, the clavicular and the sternal head, and you split between that. Once you split the fibers of the pectoralis major, you'll see the pectoralis minor beneath, and the pocket actually lies between these two, and you can put the device in there. For closure, again, there are various approaches. Usually subcutaneous is closed in two separate layers with 2-0 vicryl. Whereas for skin, some people prefer to do interrupted proline sutures and then remove the sutures after 7 days. We have consistently been doing subcuticular sutures for a long time, and it's very comfortable because you can discharge the patient on the second day and you don't need to call the patient back for any suture removal. It all gets absorbed by itself. So cosmetically also, You don't get any suture marks. It gives a very nice, neat result. Some aspects of post-implant care that I wanted to discuss. Some centers and some physicians recommend complete immobilization and bed rest. I know some people go all the way to splinting the left hand, keeping the patient in bed for 48 hours and things like this. It's generally not recommended to do that. So I try to mobilize patients early. We usually give them about half to 1 hour because they've been given some sedation, but after that it's better to get the patients up and walking. The only restriction of movement that we advise usually is raising the shoulder, the left hand above shoulder level. So excessive movements you avoid for about 4 weeks, but otherwise usually recommend them to move the left hand arm freely and walk around. Now the logic is that in 2-3 days your lead is not going to get fixed. So if your lead is unstable enough to get dislodged by the patient standing up and walking, it is better that it dislodges and you know it in hospital and reposition it rather than do that. You're keeping a patient in bed for 3 days and then patient goes home and gets a dislodgement. And a patient who is mobilized early has less pain, less risk of deep venous thrombosis and pulmonary embolisms. So again, those are benefits. And then other important thing, post-procedure, you may need some amount of analgesia for the first 3 to 4 days. And if you have done punctures, if you've done subclavian vein puncture for sure, or if you've done axillary vein punctures, multiple punctures, and you want to be sure you've not got a pneumothorax, you can do a chest X-ray. Typically, we do it after a few hours because sometimes there may be a small leak and you want to screen for that. So we usually do after 4 to 6 hours and look for a pneumothorax. Now, it would ideally you always you can check for pacemaker function on an ECG, and it's also good practice to check the device so that you check the programming, reprogram if required, everything before the patient gets discharged. Now, antibiotics, people have different protocols, but the most important antibiotic dose is the perioperative dose, and that ideally should be given a little before the incision so that while you're incising itself, there is therapeutic blood levels of the antibiotic. That forms the most important dose. Usually, one additional dose given on the done on the evening of the procedure is again important, but beyond that the role of antibiotics is very limited. That definitely is not required to continue antibiotics for 7 days or 2 weeks and all this. Shower, again, ideally most surgeons would recommend for all minor surgical procedures that shower is done early, so there's no real scientific logic in keeping a wound dry and avoiding it getting wet. So we usually recommend patients to have a bath by 3rd or 4th day and tell them to nicely soap, clean, and have a bath. By 3rd day, usually you don't need any further dressing. So a post-procedure X-ray, this is actually done somewhere else, but you can see a small pneumothorax. So if you do an X-ray, watch for a pneumothorax, and some of the smaller pneumothoraxes, nothing may be required, but if it's large, you might have to drain it. Some of the regular complications and a few tips on how to avoid, and with that I'll close and we can take some discussion. So the most feared probably is infection. So one thing I would say is that you should monitor your infection rates. So one rate at least, which is infections do tend to keep happening over a long term, but I think the infections happening in the first 6 months probably reflects your intra-procedural asepsis and other issues. So you should keep track of what is the rate of infection pocket or like CIED infection in the first 6 months after implants. So generally international rates would be about 2% or so. And if your rates are higher than this, it's a cause for concern, and you should review all your practices. You should have a hospital infection team come and see the whole cath lab. They may have to lift swabs from various places and check for possible organisms growing and various things that you use in the lab. So that is something. So keep track of what you're doing, and if your infection rates are high, take strong steps to bring it down. The most important thing for infection is, of course, to maintain good aseptic practices, which means washing hands before the procedure, double gloves, using masks and gowns, and reducing the number of personnel in the lab. So these are all very important in terms of maintaining very good asepsis. Antibiotics are not a solution. although the perioperative dose does reduce infection, simply dumping a lot of, say, the newest antibiotics is not going to bring down the infection. In most series, when people look at infections, one of the predictors is use of temporary pacing. So again, how aggressive people are in using temporary pacing varies among centers. We are very conservative and use temporary pacing very, very rarely, whereas some centers would routinely put a temporary for every patient who undergoes a procedure. So you have to find a middle path. Most patients do not require temporary, and just keep it in mind that putting in a temporary adds a small, increases the risk of DVT, adds a small risk of perforation, and adds to your risk of infection. So unless you have benefits which clearly outweigh all these risks, try to avoid using a temporary. Patients who are diabetic, see that their blood sugars are controlled well. Perioperative period, not well controlled blood sugars can increase the risk of infection. Keeping the procedure short is again a good way to reduce your infection risk. So that is again something to keep in mind. So you should have some ideas of what is the usual procedure time it takes, and if your procedure times are too long, you might have to review your practices to see why it's too long, and if required, train with someone or get a proctor to help you bring down the procedure time. Usual, I think an experienced center is a single chamber device should take about 30 minutes, a dual chamber device should take about 45 minutes. So let's say up to about double this is acceptable. So but if you're taking more than 1.5 hours to do a dual chamber device, you should probably review your practices to see if there are issues. Now the last two specifically are there because if one is repeat procedures are all associated with a higher risk of infection. So if you have a lead dislodgement and you have to go back next day to open, this patient is going to have a much higher risk of infection compared to a patient where you did not have to open. So when you do it first time, do everything well. You should not have lead dislodgements. You should not have a hematoma that you have to reopen for. So all these things increase risk of infection. So that is another important thing. And what I mentioned before, what looks like late infection, people come with erosion and then secondary infection after 2 years or 3 years after implant, usually because of bad pocket placement. So avoid that. The other probably commonest problem is lead dislodgement, which, like I said, is you will see a definite learning curve. Again, if you follow your practice, you will see that in your first year you have some lead dislodgements, and once you've been doing for some, lead dislodgement rate comes down to almost zero. So with current active fixation leads, once your experience, lead dislodgement rate should be extremely small. So using active fixation leads helps. When you put an active fixation lead, make sure that you have good contact. Okay, so what we do is we always see whether the screw is deployed, but you have to make sure that the screw is really deployed into muscle. So for this, when you're deploying, you should ensure that your lead is pushing against muscle. And two, you can look for current of injury. You can look at it when you connect to a PSA, always look at the electrograms. In your bipolar electrogram itself, you can look at the current of injury, but if required, you can connect it as a unipolar electrogram from the distal tip and you'll see the current of injury well. A good current of injury tells you that you're nicely fixed into the myocardium. And then again, usually good fixation to the myocardium gives you a good slew rate. And then, and this I already discussed, fix your lead well in the pocket using a suture sleeve. Now, perforation is something again which happens once in a while, which is usually avoidable. The most important thing a way to avoid is to know which patients are at risk, which locations are at risk. So the typical patient who has a perforation is an elderly female patient with a low body weight. So when you see these thin, older female patients, know that they are very high risk for perforation and be very careful. They have a very thin heart and multiple places you can perforate. But the specific locations, two specific locations I would mention are right ventricular apex, very thin part. Be always careful when you put leads in the apex. And the other is the lateral right atrium. So lateral right atrium again is very thin. There are some muscle fibers with interspersed with thin areas which are, if you transilluminate, you will see it. You can see light coming from the other side. So very thin. When you put an active fixation lead there, you can perforate. So again, be very careful with that. And this point I mentioned before, remember that the lead stiffness increases significantly when it has a stylet inside. So that is something you should be aware of. You should also always be aware what kind of stylet you're using. So sometimes to get a lead into the apex, you may need to use a stiff stylet. But once you go towards the apex, you remove the stiff stylet, put a soft stylet. when you're finally placing the lead in the apex. So always be aware of what stylet you have in and how stiff the lead is. This is long back as one of our residents was doing this procedure where there was a perforation. So you can see here, trying to place a passive fixation lead, and actually as soon as it is in the apex, the stylet has been pulled back. But this is an old female. You can see from the way the heart is positioned, this is a thin asthenic patient, and you can see the lead just pop out into the pericardial space. So just go there, not even too much of a push, but just trying to place it there. You can see that it just pops out into the pericardium. So you can get perforation, and then this patient had to have a pericardiocentesis. And this is a patient where there was a left SVC. Because the lead comes out of the left SVC like this, we had to screw this in the atrial in the lateral atrium, and this stress as it pushes it there, lead perforated out into the lung, and then we had to pull it back and reposition it. So things that can happen. So these are locations that you have to be careful about. Not very common to get hematomas, but you can get once in a while. Now, some of the points regarding this, I've already talked about antiplatelets. Patients who are on clopidogrel, patients who are on dual antiplatelets do have a higher risk of bleeding, so be careful there. But aspirin, you almost see no difference in somebody on aspirin versus somebody who's not on aspirin. So aspirin usually doesn't cause much problem with bleeding. Anticoagulants, the usual protocol before used to be to stop anticoagulation, put them on low molecular weight heparin, and that clearly results in much higher bleeding, especially with low molecular weight heparin. So if you do that for some reason, it's better to do unfractionated heparin. But remember that unfractionated heparin giving adequate anticoagulation, you need APTT monitoring, and which has to be done frequently, and adjusting the dose of heparin. It's very difficult to do that properly. So very clearly, a lot of evidence is there. People are always worried about doing this because you see an INR of 2.3 and you think whether you can operate. Don't worry about that. If it's a patient, say with a mechanical mitral valve and you're doing a procedure, safest way to do it is to do on anticoagulation with therapeutic INR. That way you clearly reduce your risk of strokes as well as the risk of major hematomas. But definitely you talk to the patient about a higher risk of bleeding in this situation. Prefer to use cautery, and compared to another, where regular patients where small bleeders you might leave alone, here you obsessively catch all the small bleeders, see that everything is cauterized well, there's no small ooze when you close the thing. And again, like I mentioned before, don't be afraid of sharp dissection. Blunt dissection tends to produce more bleeding. If you do sharp dissection, stay in facial planes, bleeding tends to be less. So with that, I'll stop. Let me see what messages are there in the chat and in questions, and then we can start doing that. Okay, so first let me take the question which I see in question answer. So the question is, if a lead passes via CS into LV and we decide to keep it there, do we need to? Okay, no. So like I said, a little uncommon. The more common thing that happens is it goes through a PFO into the LA and the LV. So there the lead is endocardially in the LV, and we've had an instance where it's implanted outside, or this was done long back, and after a year or 2 years you realize that this has happened and lead is actually lying in the left ventricle. So you see that the pace morphology is a full right bundle, and then you take them in and do a fluoro and you confirm that it is in the left ventricle. In that case, at that point, a lead extraction from there might be difficult. You may decide in that case to keep it there, and in that case you need to use systemic anticoagulation. So patient has to be on oral anticoagulation with therapeutic INRs. But if you put into the coronary sinus, that is lying on the epicardial part of the LV, it is not lying inside the systemic, inside the left ventricle. There you do not need to use anticoagulants. So that is just like a CSA. So there you do not need to use anticoagulants. And I think there was another question in chat. So let's see that. Chat, somebody is asked, can you please explain lead crush? So what lead crushes is basically, so you'll experience this if you do subclavian punctures. Especially, like I said, if you put a roll of towel under the between the shoulder blades, and then you do the subclavian puncture, and your needle actually passes, through the costoclavicular ligament. So you're going between the first rib and the clavicle, and you put a wire, and then when you take the sheath itself, you'll experience some resistance. You're going through the ligament there; it's a tight space. And like I said, when you take off the towel, that space may narrow down further. So Now, when you have a lead going through that, this lead gets pinched between the clavicle and the first rib, and this is called a lead crush. So over time, this pinching affects the lead insulation and the lead conductor, can result in conductor breakage and all. So that is what is lead crush. So this lead crush happens with subclavian puncture, because the subclavian you're puncturing it medial to the first rib. So the first rib to clavicle is going by your puncture route. Whereas if you do with an axillary puncture or a cephalic vein, you've got into the vein lateral to the first rib itself. So you cross this area through a vein which doesn't get crushed. So crush usually only happens with subclavian vein puncture. So in questions, so Sai Krishna has asked, if lead is perforated into pericardium, incidentally detected on follow-up and lead parameters are fine, what should do? So usually, if once it perforates into pericardium, lead parameters are not fine generally. Often, one thing that happens is sometimes you get phrenic nerve capture. Often the threshold goes up. So very uncommon that it happens that it is fine. But suppose you did it during the procedure, you didn't realize, next day or the day after you have a small effusion and you find that your lead is out, I would say it is better to try and withdraw the lead and place endocardially, because this can keep on migrating and it can result in problems. So generally, I would prefer to put it back. So generally, if you pull the lead back in, the effusion doesn't increase too much. You can just stay ready for pericardiocentesis, and it doesn't increase too much, and then you can place the lead in the new place. Patient on dual antiplatelet after PCI needs PPI. What is your practice on withholding antiplatelet? So I discussed this. What I mentioned is that if you have to decide based on the clinical circumstances. If, for example, it's 1 year after a drug-eluting stent, patient is on dual antiplatelet, you're giving it just because you feel it's safer to reduce stent thrombosis. But by guidelines, you don't really need to give dual antiplatelet. In that situation, I would stop clopidogrel for 4-5 days and then do the procedure. But if a patient has had, so this is happening more and more now, that patient has, say, as a primary PCI, patient might have got this, and patient is on dual antiplatelet, and then patient develops BT, and then patient needs an ICD implant. There, where you cannot, if you stop the dual antiplatelet, you have a high risk of stent thrombosis. You definitely will not withhold the antiplatelet. You do it on antiplatelets. You just take your usual precautions. You can have cross-matching ready, and you can have, but otherwise, you, like I said, is one option is use cautery. Be very careful. And I talked to the patients about a higher risk of bleeding, but generally, we've not had major hematomas with this. So you tend to get some amount of skin bruising and ecchymosis, but not really had major hematomas with this. Patient on single antiplatelet, what is your practice? So if it's a single antiplatelet, and like I said, if it is single antiplatelet aspirin, there's usually no issue. If it is single antiplatelet clopidogrel, if there was clearly a reason to give an antiplatelet, let's say patient has had an MI before, still has coronary artery disease, and there is a reason why you're specifically giving clopidogrel instead of aspirin. Say patient has had a major GI bleed, had a a bleeding ulcer, and so you don't want to give aspirin. So if there's a clear reason, you can do it on clopidogrel. So just like that, but if just patient preference or physician preference that they've given clopidogrel instead of giving aspirin, I would try to stop the clopidogrel, change it over to aspirin, and try to do it on aspirin, because definitely the bleeding risk is smaller. Why no need of anticoagulants in RV system as compared to LV? Because the leads tend to have small clots form on them, but these tend to be very small clots. Now in the RV, such small clots, even if it goes into the pulmonary arterial tree, doesn't produce any major pulmonary embolism. So you don't really need to put them on anticoagulation. Whereas if you put a lead in the LV, once the lead is on the LV, even if it's a minuscule small clot, if it dislodges into the circulation, it can go into the brain, where of course it can produce a major stroke. So that is why you need to anticoagulate them. This also applies if a patient has an intracardiac shunt, which is uncorrected. So if patient has an ASD or a small VSD, where even if there's no Eisenmengerization, you can have intermittent right to left shunts. It's safer to keep these patients on systemic anticoagulation unless you're closing the shunt. So in patients in RV with intracardiac shunts or with lead in LV, always anticoagulate. For leads left in situ during a PG change due to lead parameter abnormality, is anticoagulation long time required? No, so like we discussed, any leads in the right side, you don't need anticoagulation. I think what you're asking is patients, for example, as a dual chamber device and has ventricular lead malfunction, and you are putting a new ventricular lead while the old lead is left in situ. So your patient will end up with 3 leads, but still all the leads are in the right ventricle. We don't give them anticoagulation. So we don't give them anticoagulation or antiplatelets. Antibiotic prophylaxis is not required. So pacemaker leads are do not require antibiotic prophylaxis. So the preferred antibiotics, cefazolin is the preferred antibiotic because you usually want gram-positive coverage. So earlier generation cephalosporins is preferred. So the general preference is usually for cefazolin, and for patients who are cephalosporin penicillin sensitive is to give vancomycin. So that is the usual recommended approach. Yeah, so there's a good question on instilling local antibiotics. So the idea is that you instill an antibiotic which does not usually get absorbed in the pocket. Now, this is done at most centers. So we do this, we instill gentamicin, but the evidence for this is not very strong. So proper trials have not been done, and most of the expert consensus is that it may or may not be useful. Nobody really knows how useful it is. But the thing is that it has very little negative sides to it. So the only thing is that gentamicin, small amount can get absorbed systemically. So in somebody with renal failure or some elderly, we try to avoid using it, but otherwise we do it. How much real benefit it has is not known, but most people do it. So I would say we can still continue to do it for the small possible benefit. So this Krishna's question is, which site apart from RV apex you prefer for RV lead? So like I said, now 95% or 95% of the leads we actually place in the mid septum. So again, sort of evolution of our practice has been, say 10-15 years back, all leads were placed in the apex. Then what we started doing is patients with congenital heart block, younger patients, we started putting leads in the RVOT. Compared to RVOT, I think the mid septum is a little easier to do and is a more stable position. So the RVOT, it's hanging up from higher and slight chance of dislodgement is there. Mid septum tends to be a much more stable place, but otherwise you get nice narrow QRS with both these. So now our preferred approach, 90-95% of the RV lead placements are in the mid septum. So for cephalic vein approach, what we do is, like I said, our incision. The first is it's a horizontal incision. Okay, so we do a horizontal incision. Now horizontal means it is not parallel to the clavicle. It is horizontal. So it's usually at a slight angle to the clavicle. We do this 2 finger breadths below the clavicle. Okay, so that is better. And then what we do is you identify the deltopectoral groove. You can see this as a groove on the skin. If that is not seen well, you can palpate and see it as a dip between the deltoid muscle laterally and the pectoralis muscle medially. You will be able to palpate like a valley. So that is a deltopectoral groove. So now you see that your incision extends up to this groove laterally. So the incision should start at this groove and go medially. So that is sort of the landmark. Once you do like that, your lateral part of the incision contains the groove. And so you'll see the deltopectoral fat there, exactly like I showed in that figure, and then you can go ahead and dissect into that to get the cephalic. Yeah, so to views to confirm. So the ideal is that so the main problem fluoroscopically is that it can be quite difficult to identify whether you're really in the septum or on the free wall of the right ventricle. So almost all fluoroscopy can be fallacious, and people have done with CT studies later that, by fluoroscopy or other criteria, you think you're on the septum and finally it's actually not on the septum. So you should try to identify. The best view to identify is a LAO of about 45 degrees, where you'll see the lead going posteriorly, that is towards the spine, and it should be pointing well towards the spine to identify septal placement. Also look on the ECG that when you pace, you get QS in lead 1 and AVL. For obese, So obese, only thing is, if you're going to dissect for the cephalic vein, sometimes there's a lot of fat that you have to dissect and go down. So you can decide beforehand whether you want to do that or directly even go for puncture. And again, in obese and some of the women, sometimes you have a lot of subcutaneous fat, and the pocket sometimes tends to become made of the fat. So that you should try to avoid doing that. You should get below all the fat, reach to the fascia, and make the pocket over the fascia. Like I was saying, if you make the pocket in the fat, you will see after 2 years when they come that the device would have gone low down. So if the fat is very loose, it just easily tends to keep on extending, and the pocket it migrates in the pocket. So I would say these are specific problems that you have in the obese. Apart from that, I can't think of any other major problems. Thrombophlebitis. Yeah, if your thrombophlebitis, for example, if it has developed bacterial infections, so thrombophlebitis often is sterile thrombophlebitis. It's inflammation, like for example with amiodarone this thing. But if it's an infected thrombophlebitis, it would definitely risk. So any infections, if it is there, always try to wait for the infection to clear before taking up the patient. If the patient has abscess somewhere, has clearly thrombophlebitis, wait for some time for that to clear before taking up the patient for procedure. CIED infections are very difficult for the patient and for the physician to manage. As far as possible, you should take all steps to avoid the patient developing infection. So, what do you mean by slew rate and current of injury? So we actually in the agenda it was circulated that also discuss how to check the leads during the procedure, but that was a little long, and I thought we can cover that in a different place. So I didn't cover that. But what you do each time you put in a lead, of course, is that we connect it to the PSA. PSA stands for Pacing System Analyzer. The Pacing System Analyzers are built into the programmers usually. Once you connect to a PSA, you have a screen where you can see, if you can directly connect ECGs also, you can see ECGs in that case. You can see electrograms recorded from the lead. You can see event markers, and down you can see the measurements. Now, the first thing you should do is you should look at the electrogram. So when you look at the electrogram without pacing, you see the intrinsic signal, and beyond the intrinsic signal, you see what looks like ST elevation. That is current of injury. So this ST elevation, like I said, is more prominent if you see the unipolar. So for unipolar, you connect the distal clip to the distal pin, but the proximal you connect it to skin, then you get a unipolar recording. Unipolar recording, if you know about MAP recordings, monophasic action potential, you put a catheter and push it into muscle, you can record something like an action potential. So it's the same principle here. When it is pushed with pressure, you get current of injury. It'll look like an action potential. You'll get that ST elevation like a plateau. If you see that, that is current of injury. So there's no cutoff for that, but you see that kind of good ST elevation. It tells you that you've injured myocardium, so you're not floating in myocardium. For slew rate, I think already Govind discussed when discussing one of the previous sessions. Slew rate basically is dV by dt. So it is how fast the voltage changes with time. So it basically tells you how sharp the upstroke is, upstroke or downstroke of the electrical signal is. So even visually you can see it by seeing how sharp the signal is, but it also gives a slew rate measurement there. And again, if you're echo. So what are the important things you see for the echo? So one is LV function, because if LV function is less than 40 and your patient is going to need pacing, strongly you have to, the guidelines actually says you have to consider CRT implantation. So that is one thing. So if there's pre-existing LV dysfunction, high risk that the LV dysfunction will worsen, the patient will develop pacing induced cardiomyopathy. So consider IV pacing. So for that reason, one is you look at LV function. Second thing you look at is you look at the coronary sinus size. If coronary sinus looks dilated, then Lead parameters have to be checked immediately or after a few days for inflammation to settle to get true values. So the way lead parameters are checked, usually, like I mentioned, as soon as the lead is placed, you check. Now, at that point, one thing to remember is for active fixation leads, the threshold takes some time to stabilize. Actually, it takes about 5 minutes to stabilize. So what we do is we screw it in and we check it. But suppose your threshold is 2 or 2.5, don't immediately unscrew and place in a new place. You wait for 2 minutes and then check it again. So that is one thing, an acute rise in threshold as soon as you screw in. Now, beyond that, the inflammation, that threshold rise progresses over a couple of weeks. So that you can't really wait for and check. So the wait around, so that one is that this kind of acute rise and subacute rise in threshold that tends to happen in the first 4 to 6 weeks is very much mitigated now with steroid eluting lead. So that is not that much of an issue. And the other thing to mitigate that is that usually most of the devices come with a higher programmed output. So like Medtronic devices, it's at 3.5 volts when it comes in factory settings. So usually leave them at 3.5 volts in the first. And we usually check the device after 6 weeks, at which time point we reduce it, at which time point we decide that as chronic threshold and reduce the output. So that is what we usually do. Now, in addition, what I said is that a third day when you're discharging the patient, you can check the leads. There it is primarily to look for lead dislodgement. If you've got either macro dislodgement or micro dislodgement with threshold rise, you'll be able to identify. So you can, ideal is to check it. So you should probably check that. In atrial fibrillation, post-PCI, stop aspirin, NOACs and clopidogrel, high risk of bleeding, skin incision. Most patients are okay with aspirin. No. So what you're saying is that in a patient who is on dual antiplatelets, if you have to add anticoagulation because patient is in atrial fibrillation with a high charge score, triple therapy is generally discouraged. And what we usually recommend is double therapy with clopidogrel and either NOACs or warfarin. So triple therapy has a high bleeding risk. So that is why we do that. But what I'm telling you is aspirin in isolation, the bleeding risk is very small. That is what we've generally found. So aspirin in isolation for surgical procedures, bleeding risk is very small. So it is usually not a concern because previously people used to do this. If somebody was on aspirin, you should stop aspirin for 1 week and then only take up for pacemaker implant. So you don't need to do that. So practical experience, we found that it's usually not a problem at all. So with that, there are no more questions, and we've come to 8:30. So hope it was useful for both of you. So Ganesan, if you have a closing remarks, and we can, I think, close after that. Hello.
Oh, I'm so sorry. I was talking over a muted phone.
Yeah, I thought so. Okay.
So I was telling that the next session is going to be on 21st of November, because next Saturday is Diwali. So we will have the next session, same time, 7 o'clock by November 21. Thank you, Dr. Raja Selvaraj, and for your scholarly disposition on this implantation lecture. And thank you for the attendees also for staying back till 8:30. Thanks a lot. We'll meet on 21st, 7 o'clock. Yes, sir.
Yeah, thanks again to the Medtronic team, and again thanks to the participants. What we found in all the sessions as participants are very interactive and obviously shows that you're all interested in finding this interesting. So thanks everyone. So we'll see you in 2 weeks then.
Yes.
Good night.
Good night, sir.